All right, welcome to my master class, the Hormone Truths about perimenopause and menopause. Thanks for joining me today. Um, my name is Dr. Carmen Jones. I'm a licensed naturopathic doctor and an herbalist, and I'm excited about this class for a lot of different reasons. But the more that I'm working with folks and trying to help people address their concerns, the more perimenopause and menopause keeps coming up and up. And so I suspect that is also why you guys subscribe to this master class. If you're catching the replay, will you please, if you have questions that don't get addressed, please shoot me a message. If you have questions today, please put them in the chat, and I will do my best to answer them. Now, some of you guys submitted questions early, which is fantastic. I'm going to address those as well so we just get a better understanding of what perimenopause means, learning a little bit more about our bodies, how our bodies work, why the symptoms of perimenopause and menopause can be so vast and how we can support it and where we can support the body. So this is a three-part series. So tonight we're just kind of laying the groundwork to help to understand um, what the cycles look like as far as our hormone changes. When we say hormones, what all's involved. So we, yeah, lay that kind of groundwork. And then tomorrow's class, we will dive in a little bit deeper and understand a little bit more, like zoom out a little bit as far as our detox pathways and our gut health and how that influences our hormones and how that influences, right, the intensity of perimenopause symptoms. And then the last class, we will get a better understanding as to, what all the organ systems that are involved. We're also going to touch on a mind-body piece and understand a little bit more in depth of our emotion and stress and how that affects things. I'm going to touch base just really briefly a little bit on the energetics in that last class so we can kind of get a whole person approach. So, I am excited for you guys to be here, and I appreciate you taking the time um, to choose you and to yeah, get a better understanding about what perimenopause and menopause means. I think this is one of those things that we are, huh, there's a lot of changes, or in my, totally my opinion and my bias, there's a lot of deficiencies and discrepancies in women's health, especially in this country, and definitely perimenopause and understanding menopause is one of them. So, I'm hoping that after today's class, at least we will have a little bit of a better understanding. So I do have a PowerPoint, so let me get that pulled up for us here. Um, so I have something to kind of guide me. All right. So, the reason why I called this our hormone truth is because I feel like a lot of this is, some of it is a little bit when it comes to women's health, this our understanding, sometimes it's a little bit of a myth busting uh, journey, and sometimes it's like, okay, well, what's really happening, and sometimes it's a matter of like understanding what's happening and sort of that validation. Even when we're told that, right, like some of these symptoms might be in our head, or some of those symptoms are not perimenopause, right, or hormone related. And so I, yeah, wanted to help us just again to get a better understanding. So I'm going to first give you a little bit of introduction because I think I have some folks who are a little bit new to me that are joining us. And so I want to give us kind of a an outline of naturopathic medicine, what it is. If you're not familiar with naturopathic medicine, what does it mean? How is my perspective a little bit different? So you kind of get an idea of why I started this masterclass. So, naturopathic medicine is its own branch of medicine. So, very much like MDs or medical doctors, DOs, doctors of osteopathic medicine, naturopathic medical doctors are its own line or lineage of medicine. Other terms you may be familiar with, have heard of, are like functional medicine, integrative medicine, holistic medicine, natural healing. They're all similar but different. One of the foundations of naturopathic medicine is this idea of vis medicatrix naturae, which is a Latin term, but essentially it means the healing power of nature. So we recognize that our bodies resonate with nature, right? And what that means is that our body also has the ability to heal itself. And when we look towards different therapies, we're looking more towards what people would consider holistic, natural, right, nature formulated therapies. Now, when we look at the the therapies, naturopathic medicine's an umbrella. And underneath that umbrella is where we look at the different modalities or therapies. So botanical medicine, plant medicine, herbalism, clinical nutrition, holistic nutrition, food as medicine falls within the naturopathic umbrella. And I will share with you at the end of today some food as medicine things to start incorporating into um, our lifestyle to help to support our hormone balance. Mind body medicine, homeopathic medicine, flower essences, those are considered energetic medicines. They also work with our body, but all fall underneath the umbrella of naturopathic medicine. So the idea is that we're addressing the whole person, right? It's treating or understanding the individual, not the disease, right? We are all unique human beings, and with that comes not just our physical health, but our physical body, our mental body, our emotional body, and our spiritual body. That's what creates our the whole picture that you are today. So, the goal with this series is to understand all of those components and how that affects our hormone shifts, our hormone changes or transitions. Mm. So, I like to describe, in case you guys are still not familiar with naturopathic medicine, I like to describe this as a paradigm shift in the way that we're thinking and understanding our body and how we're going to support it, right? So, if you have a house, and you've built a structure or you have a structure, usually a home or a house, that structure creates or is built with function, right? It's built with a purpose, right? Whether that is from like a cabin to a mansion, right? Open concept, a ranch style, that house has a function, right? And the same thing, if this is a metaphor for our body, right? Our body has certain functions, and when they are working, I would say optimally, or when they are working well, things go smoothly, right? Like things will go smoothly, yeah, in a household as well. Well, what happens when that structure is compromised? Um, what do we do? Well, in case of a fire, oftentimes we call the fire department or we, get water and try to put that fire out. Um, and when we put that fire out, sometimes there's collateral damage in that process, right? Sometimes we've got broken windows, um, water damage, broken doors, and walls and things like that. And that's what it took to put that fire out, right? If this is a metaphor for our body, and that fire is chronic disease or inflammation, right? Or a flare up. Sometimes we have to look outside of that house or outside of our structure for repair, right? So sometimes in these situations, we're turning to Western medicine. We're turning to something, right, like acute to put this fire out. From the naturopathic perspective, we're trying to shift so that we are looking at the structure, inspecting it, if you will, right? On a regular basis. I tell people we're listening to our body for a reason. Um, we're looking at, right, the wiring. We're looking at the foundation to prevent these fires, right? To prevent accidents or things like that from occurring within the structure. So the same for goes the same idea goes that if we're in, a hormone transition or a hormone shift, and it feels like our body's on fire, right, or everything is kind of crumbling down around us, um, we look at where we can strengthen, right, that structure, whether it's addressing the foundation, like the, electrical, the ventilation, or if we start before we're in a 100% transition, if we start addressing the shift within our hormones and within the body, sometimes we can move through perimenopause and menopause without significant um, symptoms, right? I like to talk about a lot about root causes, right? And understanding where dis-ease comes from, because things like diabetes, heart disease, right, obesity, autoimmune conditions, even perimenopause, those may be things that are diagnosed based on a certain criteria, and they may come with a certain set of symptoms, but that doesn't tell me why those things have gone awry, right? Or like why something has happened. So you could have a dozen people with diabetes, and you could have a dozen different root causes or a dozen different um, reasons why their blood sugars are not under control. And so this is what we're talking about when we say address the individual, not just the disease. So that applies to to our hormone shifts as well. Um, I love to share this illness wellness continuum. This is my last intro slide because even though it's depicted linearly, and we know that our health is not linear at all, it's still, I think, a nice infographic to help us kind of understand things. Because if we think, we're sitting kind of in this neutral position on this continuum, 0 and 1, right, is disease, death, 10 is our optimal health. And if we sit right like in this 5, this neutral, we don't have symptoms, we don't have a diagnosis, we feel pretty good. We can have this false impression that we're healthy, right? Like that we're doing really well. And what this highlights is that just not having symptoms isn't enough to be healthy, if you will, right? We actively have to be making choices and decisions to promote our health. So that health awareness, education, stress management, right? With the difference between moving from a 5 to a 6, 7, 8, 9 is when we're in a 10, we're doing all of those things to actively, right, maintain and keep our health on a physical level, an emotional level, a mental level, and a spiritual level. And so that's kind of what keeps us in this kind of this high um, wellness end of this continuum. When we start to move into poor health or dysfunction, right? Sometimes if we don't have the opportunity to kind of zoom out and kind of see the whole picture or our health on a continuum, sometimes we may not always like understand where we are. And so I like to share this to help us self-assess where things are and where we want to be, right? So we're talking about hormones, right? We're talking about hormones. First, let's define hormones. Okay. The majority of the time when we talk about hormones, people think estrogen and testosterone. And those are the first two out of the bat. As you say hormones, it automatically goes to estrogen and testosterone. Because that's what we've been taught. That's what's been highlighted, right? In conventional medicine. Well, there's far more hormones involved. than just testosterone and estrogen. So when we talk about hormones, we're talking about our thyroid hormone, we're talking about our cortisol or our stress hormone, and we're talking about our estrogen and testosterone, but also progesterone as well. So, where do these hormones come from? Okay. In the brain, we have a hypothalamus, and then the hypothalamus sends signals to the pituitary. And then from the pituitary, that's where it actually sends out releasing hormones to each individual organ or gland that then releases the subsequent hormones. So, for example, if people have heard of the HPT axis, that stands for hypothalamus, pituitary, and the T is for thyroid. So you get the hypothalamus, the pituitary, it releases that TSH, if you guys are familiar with that, to the thyroid, and it tells the thyroid to make the thyroid hormones, the T4, that then has to be converted to T3. The same pathway goes to the adrenals, and so in response to stress, sends signals to the adrenals to make cortisol, which is our stress hormone, which we're going to learn about a little bit more here in a little bit. The same pathway, the HPG axis, goes from the hypothalamus to the pituitary to our gonads, which is where estrogen, progesterone, and testosterone are produced. All right. For women, it's our ovaries and our breast tissue. We do see as we move into menopause, we do see changes in the production of estrogen and progesterone and testosterone in still the breast tissue, but also the fat tissue and a little bit in the adrenals as well. But this is the kind of the powerhouse of where our hormones come from, if you will. Um, Remember the hypothalamus, because we're going to talk about this when we talk about the symptoms. The hypothalamus is in the brain, and not only does it dictate these releasing hormones that act on the thyroid, the adrenals, and the gonads, but it also affects our sleep, our body temperature, our appetite. All of that is dictated by the hypothalamus. And so when you start to see some of these symptoms that are associated with changes in our estrogen and our progesterone or testosterone, we can start to kind of connect some dots. Okay, so when we talk about what is perimenopause, okay, I like pictures, and so I like to share different graphs. Um, and I kind of liked the way this one was depicted. So our estrogen is in orange and our progesterone is in blue. Okay. Now down here is our ages. So you'll see when we hit puberty, you see this, we've gone from kind of a flat line to significant changes in our estrogen and our progesterone. Our progesterone, like when we hit early puberty, our estrogen hits first. Um, yeah, our estrogen rises first. This is what stimulates tissue changes, right? This is what stimulates like breast buds to develop. This is what stimulates things like pubic hair to develop, our breast tissue, right? It's also what affects our mood changes in puberty. And then the progesterone is actually what starts to dictate our periods in puberty. And then you'll see like our reproductive years, things kind of balance out, right? Our progesterone and our estrogen are supposed to be matching each other. Um, and then when we start to move to perimenopause, you can see this shift happen. And I wanted to see this because this is why we feel that shift in our body oftentimes. And again, those symptoms can kind of be a little bit intense for folks, but this is partly why we see like refer to perimenopause as like reverse puberty, right? Is because we have the same hormone shifts happening, and so this is why we have some of those changes that happen in our body. Now, there's a little bit of caveat to this. This is a very simple reproduction of our estrogen and our progesterone shifts. Okay. To be honest, we would like it to be this black and white, and it's just not. Um, but at least it gives us a little bit of an idea of like how things are supposed to change. And this is what's a little bit tricky with hormones, okay? Is because even in these, like, maybe say this is the average person, right? If this was the average person and our estrogen and our progesterone were matched, one for one, our periods were beautiful, we didn't have a lot of PMS, right? They were regular, short, not heavy, then that woman, when they get through perimenopause, will probably have very minimal symptoms. Okay. Now, for other women who their estrogen and progesterone may not be matched as beautifully as this graph, where maybe our estrogen has been more dominant, and we've experienced things like endometriosis, severe PMS, um, PMDD, fibroids, fibrocystic breasts, right? If we've experienced things like hypothyroid, where our estrogen has replaced that balance with our thyroid, then our graph doesn't look like this, right? If we've experienced chronic stress or significant stress in our life, or we're currently experiencing a lot of stressors, and we're going to talk about that in a little bit more detail, then again, our estrogen and progesterone doesn't look as beautiful as this depiction. So this only shows a piece of the pie, if you will. And like I said, this isn't as simple as they depicted. But what I wanted you to see overall is that yes, our hormones do increase and they do naturally decline, right? But they don't really just like fall off of a cliff. So you'll see this kind of up and down, right? Like these are our cycles. And what we've been kind of taught is that when we hit perimenopause and menopause, our hormones just fall off a cliff. Just one day you wake up, 1 month, right? You are moving through things and it just your body just stops making hormones. And that's not entirely true. And so that's what I was hoping to um uh help us understand with this graphic. Now we're going to go into a little bit of detail about what's actually happening in between these orange and blue lines. Okay. So if you guys have worked with me before, you've probably seen this picture. Um, but I think it's worth sharing again, so that we're all on the same page, because I don't think we're taught enough about our bodies with understanding. So hopefully if we get a better understanding about our bodies, we can share that with our uh children, with our nieces, with our aunts, right, with our grandparents, our moms, because a lot of the stuff isn't talked about. So if we look at what's actually supposed to be happening in the menstrual cycle, okay? Um, okay. So up here at the very first half, this is what's happening in the ovaries. All right. We call it an ovarian cycle because this is what's happening in the ovaries. Down here, the second half of this graph, this is what's happening in the uterus. So we call this the uterine cycle. So if we just focus on the ovaries here in the first half, the two main players of hormones in the ovarian cycle is our FSH and our LH. FSH stands for follicle stimulating hormone, and these are the follicles. So when we're taught that you are born with X number of eggs, and those are the eggs you're going to have your whole life. You're not going to get any more eggs. What there actually are is they're actually follicles. And each month when we're ovulating, what happens is we have this shift of FSH and LH, and as they spike, they'll also spike with the influence of estrogen. What happens is this follicle then releases the egg in ovulation. And then the egg is supposed to go from the ovaries up to the fallopian tubes, and then into the uterus, waiting for um, fertilization and implantation, right? And then what the outside of the follicle turns into this corpus luteum, which produces a lot of progesterone to help to support our pregnancy, right? That's what's supposed to happen. Now, what we see is for some women who experience PCOS, these follicles will uh, grow, but they don't ever mature and they will turn into cysts, right? This is where cysts come from, is that sometimes we get this follicular stimulating hormone. We may have a lot of this FSH and it causes these follicles um, to start to develop and to mature, but they don't ever release. And so then they become cysts. All right. So that's what's happening in our ovaries. Now, down here at the same time, what's happening is the relationship between our estrogen and our progesterone. Now, the first half of the cycle, this first 2 weeks, which day one starts when we start bleeding. Okay, not spotting, but when we actually start bleeding is day one. So day one is the beginning of what they call the proliferative phase, or they call it the follicular phase because that follicle is developing. And estrogen's the biggest player. You'll see that here in this yellow hill, is that estrogen's the biggest player. Well, what estrogen does, it stimulates tissue growth in the uterus. Estrogen does a lot of things, and we're going to kind of start to see a little bit of that in depth here. But estrogen in the uterus stimulates tissue growth. Okay. So it is stimulating the uterine lining to get thicker. And then as it spikes, as our estrogen rises and spikes, it stimulates that LH and FSH to release that um, egg, because the idea is that the thicker the lining, right, the better it is for implantation, for that fertilized egg to implant and start growing a baby. Well, you'll see estrogen is not a big player the first half of the cycle. And then after ovulation, our progesterone starts to build up. That's this green hill here. We call this the luteal phase, the second 2 weeks of our cycle. The reason why progesterone is significant is because estrogen, you'll see it declines, and then we get a second hill back here in the luteal phase. Again, estrogen is promoting the growth of that tissue. Well, progesterone stabilizes the blood vessels because all of that tissue is full of blood vessels because that's what brings the nutrients, right, to the fetus. And so if we don't stabilize those blood vessels, then we're bleeding all of the time, because that blood flow will just kind of bust through that uterine lining and then cause our shorter periods. So we need progesterone to match our estrogen that second half of the cycle, or yeah, to stabilize those blood vessels. And then we see it naturally is supposed to decline. We naturally get a decline of progesterone and our estrogen. When that estrogen drops off, that's when our bleeding starts, right? When our progesterone drops off, I'm sorry, that's when our bleeding starts. And so we typically expect to see, I'm going to say average cycle of 28 to 31 days. Right? Cycles that are shorter than 28 days, usually we're looking at, is progesterone a culprit? Do we not have enough progesterone to match our estrogen? Or if we're having pretty intense periods or multiple periods in a month, then we're looking to see, right, where this ratio is this ratio off. Um, so this is what's typically supposed to happen, right? Now, when we look at perimenopause, technically, this is why I wanted to bring this up because they will tell you that perimenopause lasts like it can start as early as 33 years or 33 years old to 55 years old, right? That's a 20-year window. That's a very large window to have our hormones shift and our hormones change. So I think it's important to understand, yes, our hormones are always changing, but are they actually declining? The menopause diagnosis is 12 months without a period. Okay. Perimenopause, so there's like an early perimenopause and kind of a late perimenopause. But this cycle, this menstrual cycle, usually bleeding lasts about 7 days, right? Or shorter than that. In early perimenopause, we can start to see those changes of our cycle. Sometimes they will lengthen over that 7 days, or sometimes they will become shorter than that 7 days. Right. And so those are kind of like our first, like, oh, okay, something's changing, something's shifting. Now, late perimenopause is when we're skipping 2 cycles or more, or we're having a period longer than 60 days. Okay, is technically the definition of a late perimenopause. Now, we're going to talk about our hormones and some of the other relationships so we can see other variables or factors that could be contributing to changes in our period and some symptoms. So, let's see. Um, Again, if you guys have any questions when we're going through things, feel free to put them in the chat, and I will do my best to catch all of them. Okay. So, did you know that there are over 30 symptoms that are recognized for perimenopause? Okay. And this is where it can get a little bit tricky because there are some things that we expect, and there are some questions that you guys submitted that I wanted to address. Because a lot of people will think, okay, they think of menopause or perimenopause, hot flashes and night sweats. It's usually the first thing that comes up is hot flashes and night sweats. And so some people think, well, if I don't experience hot flashes and night sweats, well, maybe I'm not in perimenopause. Like, what does that mean? Well, we experience hot flashes and night sweats, and technically they're two different things. Hot flashes are a shift in that hypothalamus. Okay, so we talked about that hypothalamus being part of the HPT axis or the HPA. So the hypothalamus is kind of the control center for our body temperature and for our hormones. Okay, so if our natural rhythms have been a balanced of estrogen, progesterone, cortisol, and thyroid, and then all of a sudden you take away or you start to reduce an estrogen, or you create more cortisol, there becomes a greater differentiation, which changes the threshold of the hypothalamus. So then a hypothalamus sees that shift as, oh, we have to do something about that, right? And so it creates these hot flashes, which we call it a vasomotor shift. But essentially, what it is your body saying, okay, it's actually recognizing it as a stressor, to be honest. And it's saying, okay, we have to dilate our blood vessels, right? We have to increase our blood flow. And that's what a hot flash is. And so we start to see that shift because the change in the hypothalamus, which is because of the feedback loop that's created from our hormones, right? Now, if our hormones, so you can still have a perimenopause, and if your estrogen, progesterone, testosterone, cortisol, and thyroid have been just humming along, and they're all within ratio, then sometimes our hot flashes are very minimal or we don't experience them. But if at some point we've had an estrogen dominance or cortisol dominance, then those hot flashes and night sweats are going to be even more significant. Now, night sweats. Because there are some people who experience hot flashes and don't experience night sweats, and vice versa. Now, this is also okay. So I want to give also a caveat because I have women who are in their 20s who come in with hot flashes, and women who are in their 70s who come in with hot flashes. And so hot flashes are not um, only in the realm of menopause or estrogen. So that's why I want to make sure that we understand is that it's that ratio between all of those hormones that we talked about, our estrogen, our testosterone, our progesterone, our thyroid, and our cortisol. Because if one of those is out of ratio, then we may experience hot flashes, right? I have women in their 70s who are like, gosh, I've gone through the change 20 years ago. Why am I experiencing hot flashes? Oh, that's probably it's because they're at that point they're cortisol dominant, right? Like our cortisol is kind of taken over. For some women, it's their thyroid is deficient, and so the thyroid hormone isn't in ratio with our progesterone, right? And our estrogen and our cortisol. So one of those other hormones takes the place of that. So if you think of those hormones, right? Uh, I didn't think of this ahead of time. Like a pie, right? And all of they should be in equal slices. Well, if your thyroid slice is only 10% instead of the 20% it should be, then there's going to be a compensation, right? There, your body wants homeostasis. So there's going to be another hormone that's either over uh, uh, overcompensating for that, or there's a hormone that is dominant that's pushing that other one of those other ones out of balance. So, so we can see that. So that's not just a symptom that's just associated with perimenopause and menopause. Because sometimes, like I said, if people are like, "Well, I don't experience those symptoms, maybe I'm not in perimenopause." Well, that doesn't necessarily have to be the case. Um, Low libido, difficulty reaching orgasm. We can see this with changes in perimenopause. Now, again, if you think of these symptoms in perimenopause, just step back for a minute with me. Is if you think of these symptoms as a shift in one of those components. Okay, so we saw, um, let me go back here. When we see, oh, that's the wrong direction. This really super simple graph, you see our estrogen and our progesterone are both declining, right? And our progesterone's in blue. So our progesterone actually declines a little bit quicker than our estrogen does in perimenopause. And this is important because I'm going to explain to you the relationship between progesterone and cortisol. But when we see this is so this would be what I would consider a natural ratio, right? Like the a natural rhythm, if you will. And if there are other factors that are influencing our thyroid or our cortisol, then you don't get these nice, pretty ratios of estrogen and progesterone through perimenopause. Okay, that's what I'm trying to say. Um, so changes in libido, difficulty reaching orgasm. So we can see this for a couple different reasons. Our libido can be an issue because of stress, because of cortisol dominance. Our difficulty reaching orgasm we can experience for a couple of different reasons. It can be because of a little bit of vaginal dryness. It can be because of a shift in our testosterone as well as our estrogen. We can start to see PMS changes. So this is if when we talk about, our early and late perimenopause and where we see like changes in our period, and the timing of it is usually what we see. So you can see the technically, if perimenopause stages are defined by the timing, 7 days, plus or minus for the length of bleeding, or over 60 days without a period or two missed cycles. It doesn't talk about these symptoms, right? And so this is where understanding sort of that, how does your body compensate? So if you haven't had PMS and you start having PMS around your periods, or if you've had pretty intense PMS symptoms in the past, and all of a sudden they're like, oh, my periods aren't that bad, right? If you're not actively doing something to balance your hormones, you're like, oh, my periods aren't that intense. They're, I didn't even know it was coming this month. That can also be a sign of perimenopause. Our irregular periods, our hair loss or hair thinning. So we see, so this kind of relates to our skin changes over here, dry skin, itchy skin, feeling a crawling under the skin, our brittle nails. Um, so we know that estrogen promotes or stimulates the production of ceramides, hyaluronic acid, keratin, and collagen. Okay, so this is why we can see in perimenopause or menopause, usually menopause, things like dry skin, itching. People will describe like it feels like there's crawling sensations underneath their skin is drier. They might have crepey skin. That loss of keratin affects our hair. They estimate that 1 in 3 women experience hair thinning or hair loss in menopause. Um, and so it's that shift, that's a shift in estrogen that we visibly can see, oftentimes in our hormones, but also, yeah, physically. That lack of keratin and collagen affects our nails. We can see mood swings, so anxiety, depression, anger, and irritability. I mean, kind of the whole gamut, right, of our hormones. And sometimes people will be like, and this is why I want to address this is because if they estimate that perimenopause is from 35 years to 55 years, and we're seeing things like anxiety, depression, anger, and irritability, sometimes that directly affects our quality of life, right? It affects how we show up in our lives, in our families, in our community, in our job, right? And if we understand, okay, well, as our hormones are shifting, if that is creating a scenario that's increasing anxiety or depression, anger or irritability, and it's misdiagnosed, and not as a perimenopause, but it's maybe medicated with antidepressants or anti-anxiety meds. And maybe it's not addressing, right, the root cause for somebody. It directly affects how we show up in the world and how we can hold that space for our healing, for our balanced hormones, that homeostasis, and for our families, for our spouses, for our children, right? For our all of the above. And so we can see, so if we understand, let me back up. So if we understand that estrogen acts on receptors throughout the entire body, okay? Um, when we were embryos developing in mom's womb, we our body was responding to estrogen. So what estrogen does is it sits in those receptors and it stimulates cell growth, right? This is why we talked about estrogen and how it stimulates cellular growth within the uterine lining and causes more tissue to grow. The same thing was happening to us in development in as embryos, right? Our moms had what we call super physiologic levels of estrogen and progesterone. They had 2 to 3 times a average amount of estrogen and progesterone while they were pregnant with us. And so what did our body do? Well, it responded to those that excess estrogen and progesterone. Those her hormones sat in our receptors and caused our body to grow and to develop, right? Into the baby that we were. So that affects our nervous system, that affects our spinal cord, that affects all of our tissues. So we see the role of estrogen directly influences our neurotransmitters, our brain health. It directly influences the hippocampus, which is where we create memory. Um, and so you see, as some hormone changes can occur, if our estrogen and progesterone, again, cortisol and thyroid don't stay within ratio, and one of those other hormones has to compensate or becomes dominant for whatever reason, we will see these symptoms magnified, right? Um, let's see. I may not have put it down here together. I don't see it, but we do see changes in memory. Um, We can see headaches as well, but we can see changes in memory in perimenopause. And this is one that I like to myth bust because sometimes we're taught that, oh, well, one, we're taught that kind of our body kind of falls apart when we get older. But two, women will come to me who they've turned 40, right? And they're having troubles with memory, forgetting names, forgetting where they put their keys, walking into a room and forgetting why. People are like, oh gosh, especially if they have a family history of dementia or they've seen their mom or grandmother or aunts, right, suffer with dementia and Alzheimer's. Um, they get really scared because they're like, oh, like, am I experiencing early signs of dementia? Um, and that's not always the case, is not always early signs of dementia, but we can see the role of estrogen here as well. Because estrogen, what happens in the brain is our brain takes testosterone and takes it to estrogen. It converts it to estrogen. And so, if we don't have as much testosterone, oftentimes we may not see as much estrogen, and then it makes it challenging for that hippocampus to hold memory. Our hippocampus is also known as part of that fear center within the brain with the amygdala. And so, sometimes we can see cortisol start to take over in those areas. Sometimes we also see if women are self-conscious about their memory changes, they may not act, they may not be as involved, right, in certain things, in the, yeah, in or I don't know, take on different opportunities because they might be a little bit self-conscious or self-aware that they're noticing their memories changing, and nobody's told them, oh, it could be because our hormones are shifting. They're actually doing studies and looking at the risk of Alzheimer's and dementia in men versus women because they estimate that in postmenopausal women have less amounts of estrogen in their brain than older men. Because older men can take their testosterone and convert it to estrogen. And so, this is why some people will explore hormone replacement therapy and why they will explore things like testosterone. And they notice a significant difference in their memory, or people think, I feel like I'm losing my mind. And they notice that symptom often right away because the testosterone gets converted to estrogen in the brain. And so we need estrogen to help to support our brain health. Um, okay, we can see changes in insomnia, fatigue. Again, it's kind of two part. This can be part of the stress component with the cortisol dominant. This is also can be because it affects our hypothalamus, which is what kind of dictates that sleep cycle. Urinary frequency and recurrent UTIs. I want to bring this one up because sometimes people don't recognize this as a perimenopause symptom as either. Now, urinary frequency and recurrent UTI. So we can get this for a couple of different reasons. When we see this shift in hormones, now sometimes we can experience things like vaginal dryness or changes in the skin in the vaginal area or the vulvar area. This can change the microbiome, which makes us more susceptible to UTIs. Um, it can also change the receptors in the bladder, which is why we get kind of this frequent urination or like an increased urgency for urination. Um, that vaginal dryness, that soreness or itching can kind of changes the skin in that area. And sometimes this is things that we don't talk about, right? It might be a little bit um I don't know, taboo. Uh, but we can see this can be a this can create a situation where intercourse or sex is uncomfortable, which can lead to a little bit of a low libido or just like a lower desire because it's painful. And sometimes we don't talk about that. Conventional medicine has um, limited resources for this. Usually they're looking at like hormone replacements or like estrogen creams, where they're directly affecting the tissue in that area. But again, if we're looking to support the whole body, because usually if we're experiencing these symptoms because of a shift in estrogen, we could also be experiencing any of these other 30 symptoms. Um, Now, like I said, because this is a spectrum, right? Like people may go through perimenopause and may not experience the intensity of these symptoms, and that's okay, right? I think that that's kind of, from my perspective, I'd like that to be a little bit of our goal. But the idea with understanding some of these symptoms and what's happening in the body, again, helps us see, right, where to make that support, where to add that those foundational pieces. Because what happens is like people say, their hormones are out of balance, and then they'll go get their hormones tested, and they come back and everybody's like, oh, your hormones look great, right? Well, that's a little bit misleading. If your hormones look great, but you're experiencing anxiety, irritability, right? Hair thinning, hair loss, palpitations or dizziness. That's a little bit, yeah, misleading, and we feel very unheard. So my goal here is to, again, kind of help us see where, if there's a shift occurring, to address it sooner rather than later, to help to resolve or to at least mitigate these symptoms. That makes sense. Um, we talked about the skin, digestion changes, heartburn, constipation, and bloating. We can see the role of estrogen here. Sometimes this just gets magnified. So if we've already experienced digestion changes around our period or in that like luteal phase right before bleeding occurs, whether that's bloating or loose stools or diarrhea or constipation, sometimes that gets significantly more intense or magnified for some folks. Um, there's something that's called burning mouth syndrome that we can see. Now, some of this has to do with the mucous membranes, and again, kind of had that vaso motor those vasomotor symptoms, like similar to like the hot flash vasomotor symptoms that happen in the mouth for folks. And so I wanted to, somebody asked a question about this, so we can kind of, yes, we can see that as being a perimenopause symptom. Um, Palpitations and dizziness. So this has to do with our heart health. Now I'm going to go into a little bit more detail about this as far as like our chronic heart health and what changes with our estrogens, but we can see this as well. Allergies. This is usually a new onset of allergies. If we haven't had allergies before, and here, we're getting allergies at 40, 45 years old, it's because the estrogen's role in immune modulation or in our immune system can affect that. And then joint pain or hip pain. So we're seeing more and more a better understanding of this, like there of joint pain and hip pain being around perimenopause. And oftentimes it's misdiagnosed, to be honest. It's usually misdiagnosed as like a bursitis or a tendonitis, but it's actually considered a tendinopathy. So when we can see that role of estrogen in our joints because when we are when women are pregnant or when they're about to deliver, right, that surge of estrogen makes their joints very flexible, right? So like especially in the pelvis, we can see that because the pelvis has to open up. And so the same thing can happen is that we see those estrogen receptors in our joints and in the tendons. And so when there's a shift in that in the hormones, the being plural, hormones, we can see those receptors activated. So we can actually see some pain, joint pain, tendon pain, in perimenopause as well. And not just hip in the shoulder, right? So sometimes people will get like frozen shoulder, and they'll tell women, "Oh, we don't know what causes frozen shoulder. You're just 40 years old. That's what happens when women turn 40. You get a frozen shoulder," and that's not entirely true. It doesn't happen to everyone. It doesn't have to happen to us. That's often, yeah, another symptom of perimenopause because those tendons in the shoulder are not being nourished, right? And again, because that estrogen is being as estrogen declines, we're instead of just matching it with progesterone the way that our body normally would, it's being overcompensated by a thyroid, a testosterone, or a cortisol shift. Okay. So historically, we've been taught, right, it's always estrogen problem. My goal is to help to understand that it's not just estrogen. We've always taught PMS was too much estrogen, menopause was too little estrogen, and even andropause for men was too much estrogen. But that's such a simplistic way to describe that. There's so much more involvement in our body. Oh, okay. So I threw this graphic in as well because I wanted somebody asked another question about night sweats, and so I wanted to help us understand that relationship. Now, this is a sleep-wake cycle, and you'll see this is nighttime, right, from 6 p.m. to 6 a.m. Usually, the melatonin in this blue line is usually its highest, right? In the evening to help us fall asleep and supposed to stay asleep. The higher the melatonin, the lower the body temperature, right? So we know that our body temperature naturally declines at night. Now, if you'll see, come 6 o'clock in the morning, our cortisol starts to rise. As our cortisol rises, so does our body temperature. Just slightly, right? But it does rise. Now, when we go back and we hopefully we understood a little bit about the estrogen role in in the brain and how the estrogen influences our neurotransmitters. Our neurotransmitters like our serotonin and our melatonin. And so when we have a excess of serotonin or an excess of estrogen, it can promote more serotonin. When we're menstruating, sometimes that looks like PMDD, like premenstrual I've just lost it. Dysphoria disorder, uh, um, or like severe PMS, or sometimes like just significant mood changes in that luteal phase. Um, but so follow me. If serotonin is the precursor to melatonin and we have a drop in our estrogen, okay, and we don't have progesterone to cover that balance, then we will have less serotonin, which affects our mood, that anxiousness, that irritability, right, the depression, anger. Then we'll see a drop in melatonin as well. Well, if we have a drop in melatonin, often this is a neurotransmitter, but they also call this a hormone. The hormone that will fill in that place or compensate is cortisol, right? So if cortisol is higher in the evening instead of our melatonin, if it becomes the dominant in the evening instead of melatonin, our body temperature will rise and we will get night sweats. Right? If we experience anxiousness or chronic stress, whether we're in perimenopause or not, we can experience night sweats. And it's because cortisol is the dominant hormone in those situations. So I wanted to share that and hopefully address that connection as well. Okay. So this is an if you guys have been with me before, you've probably seen this graph because I really appreciate it. It's a super simple steroid pathway hormone. So this is how our body actually makes our estrogen and our testosterone, right? This is the relationship between, or what I call the players. Now, our body makes cholesterol, right? It makes cholesterol. Cholesterol goes to this first hormone called pregnenolone. From pregnenolone, it forks. It forks to DHEA, and then from DHEA, it feeds this leg down here. This is that gonads, the HPG axis. These are the testosterone, our estrogens, right? Um, that from that pregnenolone, if it forks, it can also go to progesterone. Progesterone goes to cortisol, or it can go to the gonad leg, our sex hormones down here. Okay. Our cortisol, right? This is the adrenal axis. So in the adrenals, our body produces cortisol and aldosterone. Aldosterone is what balances our electrolytes, and cortisol is our stress hormone. So when we experience stress, in whatever form, our body will always prioritize cortisol. This is the survival hormone, okay? But I want us to see this relationship here. So if our demand for cortisol is elevated, Or yeah, if it's elevated, then what will happen is it will always get priority. So we will always prioritize this part of the pathway. We will make cholesterol, we will go to pregnenolone, it'll go to progesterone, and then it'll feed the cortisol piece because our body's trying to keep us alive, right? This is our survival mode. Now, sometimes we can also see if there's an imbalance in these hormones and our cortisol becomes dominant as our estrogen declines or our progesterone doesn't match our estrogen, then our body will make a lot of cholesterol. So we can also notice higher cholesterol levels on our labs when we are in this state. So sometimes your hormone labs might come back all right, and they say, oh, there's nothing wrong. Your hormones look just fine. Oh, but we want to talk about your cortisol, your cholesterol, because your cholesterol is high. Cholesterol is a symptom of something, right? So if our cholesterol is high, it's often because our body is trying to catch up. It's trying to make up for an imbalance in hormones. Whether that's our testosterone, our estrogen, our cortisol, our progesterone, even these two, our pregnenolone and DHEA, our body's trying to maintain this balance, so it will make more cholesterol. And sometimes there we may be a little bit deficient in the cofactors, which I'm going to talk about here in a little bit, to move these arrows forward. Okay. Um, so oops, when we talk about this cortisol and we talk about that it's a stress hormone, what does that mean, right? There are different types of stress. There's the typical players, right? Like our financial issues, things that we worry about, emotional stress, right? Relationships, work, family, community, things like that. Even the community at large, right? Like the politics, things that are going on in the world. And then there's lifestyle stress. This sometimes is a shift, a lack of sleep, right? Our lack of relaxation, living in excess. We're constantly on the go, right? If we have overexertion, poor eating habits, if we have a lot of environmental toxicities, all of that contributes to stress in the body. Um, Physical things, allergies, infections, chronic infections, things like Lyme, tick-borne illnesses, chronic COVID, um, things like chronic mono, autoimmune conditions, right? Even medications or wound healing is a physical stressor. Accidents, surgeries, these could be contributing to our demand for that cortisol hormone. And then diet, like this kind of falls still underneath our lifestyle. If we're eating a lot of simple sugars, white carbohydrates, drinking a lot of caffeine and coffee because we're exhausted and we've got insomnia and we're not sleeping very well, but we're kind of adding fuel to that fire instead of, yeah, stepping back and, reevaluating our structure. We're creating chronic, again, more like chronic stress in the body. Well, when that demand for cortisol is high, right? Let me go back. When this demand for cortisol is high because of any of those factors, again, our body always prioritizes that. So you can see shifts more, which those translate as symptoms in the body, because we become cortisol dominant as our estrogen changes, right? Now, sometimes we can see this cortisol shift and we become cortisol dominant even when our estrogen and our progesterone are at adequate ratios, okay? Um, but it's very easy for us to become cortisol dominant. And what those symptoms look like, these might sound a little bit familiar, but we could see things like headaches, memory changes, insomnia. We can see things like hair loss, skin changes like acne, right? Increased risk for heart attacks, worse asthma. Do these sound familiar? They're very similar to a lower estrogen symptoms. And so this is where understanding where that balance comes from, right? Because if our cortisol isn't addressed, then it will very easily take over when estrogen begins to fall. And that estrogen that falls can be, yeah, is a natural process. But we want to also maintain the cortisol decline at the same time, so that cortisol is not taking over your whole pie. Um, some other symptoms that can be associated with that stress hormone cortisol, we can see changes in digestion, right? We heard this with our estrogen decline, gas, bloating, constipation. Back pain is a little bit different. Well, we talked about joint pain, hip pain, shoulder pain, tendon pain. Sometimes back pain becomes from the actual cortisol gland, which sits on top of the kidneys. So that pain is not usually in the joints that we see with cortisol. Cravings for sugar and fat. Again, if your body's in survival, it's looking for the fastest form of fuel because it says, hey, we're trying to keep her alive. Well, the fastest form of fuel is sugar, right? So our body takes that sugar. And if we are not moving or kind of closing or balancing that cortisol demand or that cortisol loop, we store it as belly fat. Okay. Now, the cortisol belly fat is different than menopause or estrogen belly fat. They're both hormones, but they act on the adipose tissue just a little bit differently. Because sometimes with estrogen, you can see a restructuring of the fat cells, and it's not necessarily that it's holding on to fat. It's just re kind of they call it restructuring. Um, and so those actually are a little bit different, but those symptoms are very similar. Again, a lower sex drive or low libido. We've heard this before. Um, we can see changes in blood pressure. This one's a little bit different. Well, no, you can see that with estrogen as well. Our blood sugar changes. The mechanism behind the blood sugar changes are different with cortisol. Because cortisol is a glucocorticosteroid. So it's a steroid hormone addressed to a glucose molecule. So it shows up differently. It'll show up as elevated blood sugars when it's actually elevated cortisol levels. Um, Aging, this is best depicted if you see a picture of the president when they went into office and then another picture at 4 years or 8 years later and they look like a completely different person. Prematurely, that's cortisol, right? That's a cortisol that kind of ages us. It affects our immune system. So estrogen actually modulates our immune system, and cortisol suppresses our immune system. This is where they get things like the steroid hormones like prednisone or prednisolone. It's actually a synthetic version of our cortisol. And so that makes us more susceptible to illness if we're suppressing our immune system. Versus like with the estrogen, the lower the estrogen reduces that inflammatory modulator, so then you're more susceptible to allergies. So it's a little bit different there. Okay. We've been talking about in the background, or I'm trying to keep in your mind the background of the thyroid component. Let me share with you this relationship between our cortisol and the thyroid. So we'll see this again, right? We talked about that HPA axis, and this is the HPT axis, the hypothalamus, right? Still in the brain, just like we talked about earlier. The pituitary is the next gland down. In the adrenals, it's the hypothalamus. The pituitary sends those signals to the adrenal cortex to release cortisol. In the thyroid, right, it sends those signals from the hypothalamus to the pituitary. That TSH to the thyroid tells the thyroid to make T4. Then it has to be converted to T3, which is what gets into the cell, dictates our metabolism, our bone health, our brain health, things like that. The more stress that we experience, our body prioritizes stress or prioritizes cortisol, right? Because again, it's that survival hormone. So you'll see the more stress we experience, this left HPA axis becomes dominant. So you'll see these dotted lines that say they inhibit, inhibition. So CRH, which is corticotropin releasing hormone, inhibits TSH. The presence of cortisol inhibits TSH, and it inhibits the conversion of T4 to T3. So when you have all of this pumping the brakes on our thyroid, right, this looks like a hypothyroid picture. That means low thyroid hormone. Okay. So then again, if we're looking at all of those hormones, I'm going to use the pie analogy because that's all I can think of right now. And that pie is supposed to have equal parts, okay? Estrogen, progesterone, testosterone, thyroid, cortisol, right? It's supposed to have five equal slices in that pie. Um, if cortisol becomes dominant, and so instead of that 20% of that pie being cortisol, it becomes 30 or 50%. Thyroid is of cortisol, thyroid's the first one to decline, right? Thyroid will be superseded by cortisol. And so we get a hypothyroid picture. Okay. Now, say we don't have a lot of stress. Say our cortisol is fine, right? And so we have those five hormones that are supposed to be in balance. Say we have a history of estrogen dominant, right? Which is our endometriosis, fibroids, right? Intense PMS. And intense PMS being like uh, heavy bleeding to the point where anemic, PMDD, right? That's a estrogen dominant picture. So then now estrogen, instead of taking up its 20%, your estrogen is taking up 30, 40% of the pie. Again, thyroid will be thyroid will take the hit, and thyroid will be less than that 20%. And it can look like a hypothyroid picture at the same time that our estrogen is dominant, right? A similar thing, we can see the PCOS, right, where our testosterone, our androgens are high. Well, if our androgens are high and they become testosterone dominant, that testosterone takes more than 20% of the pie, our thyroid will take the hit and our progesterone takes the hit, right? I should have said with the estrogen dominance, our progesterone takes the hit as well. The hypothalamus and the progesterone are always the ones that, yeah, get compensated the least. And so they're the balance. That's what we call them, the balancing hormones, right? Because they're like trying to kind of bring things back up instead of it always being dominant in one of the hormones and trying to bring that homeostasis back. Um, Hopefully that makes sense. So you can kind of see that. Now, this drives that. Okay, so this drives we're always talking about symptoms. My message home a little bit about the symptoms of stress. So what I put in yellow are anxious thoughts, are difficult with memory. These are cognitive symptoms associated with stress. For some folks, right, chronic stress can look like fearful anticipation or poor concentration. Emotionally, it can look like feelings of tension, restlessness, worries, an inability to relax, irritability, or depression. The yellow ones are what overlap with estrogen decline or the perimenopause symptoms. Behaviorally, chronic stress can look like avoidance, right? Sleep changes, difficulty completing work assignments, fidgeting, tremors, crying, clenching fists, right? Like this tightness. Physiologically, it can look like stiffness or tense muscles, grinding our teeth, TMJ. Some folks, it feels like a choking sensation or a lump in the throat, difficulty swallowing, um, urinary urgency, loss of libido, fatigue, weight changes. Sounds like our estrogen as well. Socially, sometimes this is withdrawing, right? Some folks will withdraw and seek solitude, and some people want company. We're all each, individuals. And sometimes the more stress we're under, sometimes we have difficulty relating to others because it feels like we're alone or we're a little bit of an island and other people aren't in the same boat as us. And so sometimes we can experience that. So the reason why I wanted to share this is because, again, um, we've been taught that things are so black and white. And oftentimes when we talk about perimenopause or hormone imbalances, we want to pigeonhole, right? Like we want one solution. We want it to be, okay, we've identified a thyroid problem. We've identified a cortisol problem, an estrogen problem, right? So we want to address that hormone. But that just it doesn't address the whole picture, and the whole person. Um, all right, I'm going to skip through these. So when we talk about how can we support our steroid pathways, um, uh, significant cofactors, which is what is needed to move one hormone to the next. Our body can make cholesterol all day long, but if we don't have vitamin C or vitamin D, or we're deficient in vitamin D, or we don't have the appropriate B vitamins, it's hard for our body to take cholesterol and change it to pregnenolone. If we're deficient in our B vitamins, we can't do any of these pathway or any of these um, they're called enzymes. It won't support any of these enzymes to transition to the next hormone. Um, and so this is why we talk about, right, eating the rainbow. This is why we talk about, right, making sure that we are getting those vitamins and minerals that we need from our food. So our B complexes usually are leafy greens. Our vitamin C, I'm going to talk about an adrenal cocktail at the end. Our vitamin C, it's not just supplementing, all right? I want you to understand where these things come from, because vitamin C is again, an umbrella of constituents. The most common form of vitamin C you find over the counter is actually ascorbic acid, and that's only one piece of of all of the components of vitamin C. So we want vitamin C from whole foods, right? So this is why we talk about orange juice, pineapple juice, right? The citrus fruit, things that are like orange, red, carrots, pumpkin, butternut squash, yellow peppers, red peppers, tomatoes, right, have a decent amount of vitamin C in them. If you're doing it in a supplement form, it needs to be a whole food based vitamin C. So something like with rutin in it, or acerola, or uh, citrus flavonoids, right, or bioflavonoids. It needs to be a whole foods form of vitamin C. Vitamin D, right? Well, the best we can, get out in the sunshine, let your body make vitamin D. We can get vitamin D from foods, things like eggs, mushrooms, and sunflower seeds. Um, there are some folks, I'm always going to encourage people to get your vitamin D tested. There are some folks who have a genetic SNP where sometimes it's hard for their body to use certain forms of vitamin D or to make certain forms of vitamin D. So get your vitamin D tested and see, yeah, where you are. A B complex. So this is not just B12 and folate. This is B1, 2, 3, 5, 6, 9, 12. Our green leafy vegetables are very high in our B vitamins. Pretty much, yeah, so our lettuce, right? Our leaf lettuces, our romaine, our kale, our Chinese cabbage, regular cabbage, arugula, watercress, right? All of those greens, dandelion greens, have a decent amount of B vitamins in them. Now, if you other B sources of B vitamins are whole grains, things like brown rice, quinoa, amaranth, um, brewer's yeast, pollen, miso, liver or beef organs, raw nuts, sprouts also are decent amounts of vitamin B. When we're talking about shifting our hormones, sometimes recognizing if so I didn't even bring this up. um, Insulin is another hormone, right? And I talk about the insulin more in the next master class and understanding the relationship between our estrogen, cortisol, and insulin. But if our blood sugar is not in balance as well, then technically insulin still has a slice of that pie. So again, I still oversimplified things when I tried to say there were five hormones and they're equally divided in that pie. There are more than five. And insulin is one of those players as well. So trying to maintain our blood sugar throughout the day, by understanding or consciously making an effort with our protein and our fiber and our fat and not just simple carbohydrates, makes a big difference. Because we know that our sleep and that sleep cycle is dictated through that hypothalamus, which is, again, sort of the regulator of all of our hormones. If we do our part, and making sure we get good sleep, having a good bedtime routine, not using blue light in the evenings, give yourself time and your mind and your body to wind down. We can often, yeah, it's not really overriding, but it's the physical cues that can also dictate the hormonal and the neurotransmitter cues for sleep. They all kind of go hand in hand. And so, exploring that as well. If you're looking for a good supplement for vitamin C, I talk more about magnesium in the next masterclass. Usually the goal is 1,000 milligrams 3 times a day. We usually start at 1,000 milligrams. You go up to 3,000 in divided doses. If you try to hit all 3,000 at once and you're not used to it, it can create loose stools. And so I tell folks to kind of back down. Now, technically, you can get up to 12,000 milligrams or 12 grams, but you have to work your way up. So 3,000 is usually a pretty good starting place. It helps to correct any deficiencies that we may be experiencing if you wanted to do it in supplement form. Good B complex. I like to share these recommendations because there are a lot of B vitamins out there, and there are a lot of B vitamins that are synthetic, or that don't have therapeutic doses. If you're, sometimes they do, like try to make it easy for the consumer. So they'll have like B50s or B100s where you're getting at least 50 milligrams of the B vitamins. Usually we want these forms, the pantothenic acid, the peroxidine, the folate, the methylcobalamin. So take a screenshot of these. And if you're looking for therapeutic doses, if your B vitamin, so go to your cabinet and look at your B vitamin and if you have one. And if it says your B1 is like 1.5 milligrams or 5 milligrams, and the therapeutic dose is 15 to 25, either we're going to have to increase the dose, or that's not a very good quality B vitamin. So that's why I offer these ranges for you so you can have an idea to distinguish what you already have, or if you were going to purchase something, what would be a good thing to start looking into. Okay, food is medicine. Sweet potatoes. So sweet potatoes are I don't quite think that they're a superfood, but they hit a couple of different things here. So sweet potatoes, orange, high in vitamin C, right? They are high in potassium. They help to support stress and estrogens. Okay, and I'm going to talk about this in a little bit. There's naturally something called phytoestrogens in sweet potatoes. So I encourage people to start incorporating sweet potatoes into your diet. This weekend, I made sweet potato pancakes with my niece and nephews. It's easy, sweet potatoes and eggs. And we made pancakes. We could do roasted sweet potatoes. Yeah, sweet potato fries if you're cooking them at home, right? In a good oil. But incorporating sweet potatoes can be very beneficial. Putting them in your smoothie. Helps with that stress cortisol hormone. Also helps with our estrogen hormone. Okay. It's in the same family as wild yam. So we're going to talk about that here in a minute. And then hibiscus, because I like teas. Hibiscus is really helpful in lowering our cortisol. It's also very high in vitamin C. So I'm going to share with you a recipe on how to make an adrenal cocktail. You can use hibiscus tea if you are not a fan of orange juice or if you want to mix it up. It's very high in vitamin C. That antioxidant, anti-inflammatory properties also help to protect our heart, which, yeah, is important in perimenopause and menopause as our estrogen is declining because estrogen is also protective of the heart. If we just don't have as much estrogen naturally, right, we want to find other antioxidants and alternatives. Okay, so um, bear with me. We're wrapping up here. Some foods. So phytoestrogens. I want to debunk some myths with this as well. So phytoestrogens, phyto means plant, all right? Estrogen is estrogen. So plants make or have a molecule in them that we call phytoestrogens because they look like our estrogen. So when we eat phytoestrogens, they sit in our estrogen receptors and make our body think that we have estrogen, right? And so for somebody who's still ovulating and maybe in that estrogen dominant picture, phytoestrogens can be helpful because then your body doesn't make as much estrogen. So it's not dominant and overflowing with estrogen. And also, if our we are lower or our estrogen is declining in perimenopause, phytoestrogens can still sit in those receptors and help to support our body because our body thinks we still have estrogen because it activates those receptors. So then we don't see as much symptoms or as intensity of symptoms when we're increasing our phytoestrogenic foods. Okay, so our fruits, I have the list here for you. Yeah, take a screenshot. If you guys are familiar with seed cycling, I highlighted here in orange our estrogen or our phytoestrogenic seeds that we try to incorporate are flax seeds, pumpkin seeds, and chia seeds. But those aren't the only ones. A lot of people have heard of soybeans or soy being phytoestrogenic, and for a really long time, people were like, "Oh, avoid soy because it increases our risk for like breast cancer or causes like men to grow breasts," right? Well, that's not entirely true. Um, those phytoestrogens aren't always a negative thing. But if you're not comfortable with eating soybeans, that's fine. You don't have to add it to your diet. Soy is the highest concentration of phytoestrogens, but it's not the only food that. So if you're not comfortable eating soy, that's all right. I'm not going to encourage you to start eating it. If you do eat soy or you're considering it, please make sure it's organic, non-GMO soy because a lot of the soy that's produced in this country is GMO. So please be on the lookout for that. And then our progesterone promoting nutrients, right? So we want to have a balance of these, all right? So when we're moving into perimenopause and menopause, we don't always have to emphasize seed cycling. It can be very beneficial for folks, and I'm going to talk about seed cycling in the next master class as well, in the series. But incorporating these foods in general, I like to share them with you. So if you're putting together your shopping list, you're trying to figure out, what you should start adding to your kitchen to help to support your hormones. These are all a great start, right? So for progesterone, we're usually supporting our sesame and sunflower seeds. Our sesame seeds are also like ground up is known as tahini. Our sunflower seeds, you can buy sun butter if you don't like sunflower seeds. It's like a peanut butter that's made out of sunflower seeds. Make dressings with it, put it on a sandwich, put it on your celery. Yeah, is a nice way to get those sunflower seeds in. Okay. To address the stress hormone, right, in case our stress hormone is becoming dominant or is already dominant in our picture, some of the key ingredients or components to supporting that stress response to reduce the demand for cortisol to kind of bring it back into homeostasis is this something that's called adrenal cocktail. I tell folks it's called a cocktail because you're only taking 2 ounces of it at a time, not because it has alcohol in it. Our base is a vitamin C base. So a fresh squeezed orange juice is best. If you don't tolerate orange juice, you can substitute hibiscus tea. or moringa tea. To get more electrolytes in, you can use coconut water. Usually, we're doing a potassium and a sodium because that plays to that hormone called aldosterone that we talked about in the adrenals. Um, a organic cream of tartar is a good, excellent source of potassium. Or if you can't find that, it's in the spice and baking aisle. No salt, which is a potassium bicarb. Um, a fresh Redmond's real salt, Celtic sea salt, or Himalayan pink salt will have other trace minerals besides just the sodium in it. So it's a little bit more well-rounded form of sodium. And usually we're mixing all that together and you're drinking 2 ounces twice a day, usually mid-morning, mid-afternoon. But you could take it anytime you're experiencing a little bit more stress to find that balance and to reduce the demand on our adrenals so we're not consistently cortisol dominant. Okay, so that wraps it up for me. I appreciate you guys hanging in with me here. I'm gonna check the chat to see if I have any questions. Um, Feel free to put any questions in the chat you guys might have. This is my contact information. Please share if you guys are watching this on the replay or when you get the email for the replay. Feel free to share it with your friends and family if you think that they can benefit from this information. I tell folks I always hope that you learn something new in my classes. And hopefully I will see you on the next call next tomorrow evening at 5:30 until we dive in to get a better understanding of the role of our gut health, our detox pathways, our liver, and this hormone balance and how it influences perimenopause and menopause. So I'm excited. I hope you guys come and see me tomorrow. If you have questions between now and then, feel free to drop them in an email and I will answer them in the next class. All right. Have a great evening. Thank you.